So I appreciate the opportunity to present. This is really a project that we're putting in now, and I was hoping to get some, I'll give a little bit of background, but really hoping to focus on some of the re-aim outcomes and get some feedback on those. So this is the grant. It's a R61, R33. So that's not one I'm familiar with, but it's 2 years of building deliverables and then 3 years for a trial. The speed, this is the objectives that they have there, but I just put a couple of the highlights that I think would be applicable to give you some background. So implementation of scientific solutions, real-time use of data from health systems. So it speaks to the pragmatic nature of it. Analyze local data to identify delivery gaps and then address those for the opioid overdose. So that's the first part. And then the second part, which I was going to talk about today, is the R33. So if you meet your deliverables and get chosen after the first 2 years, then you get the next 3 years to work on the project. And that is to select and deploy evidence-based interventions to fill the gaps and utilize local data. So this sort of builds on a lot of what I've done for clinical decision support and data availability within our system. I just cut and paste this in here because of the first sentence stuff. This is not nearly as deep as what Samantha just presented, but this was the first sentence of the specific aims of this, just to sort of give you a summary of what I usually do, which is to put a box at the top and kind of call it out to try and contextualize the rest of it. And so I thought it might be useful for this group as well. And so the main sort of takeaway from this is that you need to know about is that the evidence-based intervention, being the CDC opioid prescribing guidelines, is the what, and the how to deliver it is the clinical decision support. And we have a lot of different tools, which we'll figure out sort of in that first step. Importantly, the guidelines are actually changing. And so how we write the first couple of years will be interesting. And then the rough research plan is to use the user-informed CDS to help deliver these new guidelines. And similar to what we've done before, is a pragmatic cluster randomized trial across the entire UCL system in outpatient settings. So this would be any clinics, surgery, primary care, and emergency departments. And it's set up as a hybrid design, implementation effectiveness using PRISM and re-aim. And so I'll just kind of jump in. And so this is what we have set up for REACH. And this is heavily influenced by Katie's work. And so I'm going to leave this up here rather than read through it. And I would love some comments. And then in the gray boxes at the bottom are some of my initial thoughts to trigger any conversation. And I realize that not all of us are clinicians. So CDS can usually be, there's two types in general. There is passive, which sort of lives as a resource for providers to pull into their workflow, which is what providers all say they want. And then there's interruptive, which actually pushes information into your workflow. And that's the one that actually causes the most change in behavior, but really have to be sort of purposely designed, or else people reject them. So I think sort of some of the questions I have is, so we usually do a cluster randomization by balancing the groups on prior opioid prescribing and setting, meaning we pick an equal number of primary care clinics, surgical clinics, EDs. And so I'm just wondering for REACH, should this be focused on patients? If we're already controlling for clinicians and settings, when we do the REACH, does that need to be part of the numerator denominator, or do we just look at patients? Because providers can do different things for different patients, and they may not always do the same thing every time. Yeah, so that's a good question. So Amy's question was about you could start an order and not complete it. So that's one of the limitations to this, right? Is there's two ways of doing this. This is sort of a larger question, but and I think I have it on a later slide, when you're talking about clinical decision support, are we most interested in the outcome by the intervention strategy, meaning the people who interacted with the clinical decision support, or are we most interested in the patient-centered outcome, which is whether or not they got the high-risk prescription? And those are two different things, because when we go to measure it, for example, our current one, it's very easy for me to pull every time somebody interacts with the CDS. But to Amy's point, if somebody makes a decision or changes their behavior and then avoids the CDS, then the patient's still getting the right outcome, but the CDS is not going to be part of it. And so that would take it out of the denominator and the numerator. So this is a greater question, I think, for all of us, because really what we want is guideline concordant care or best practice delivered. The intervention strategy sort of is less important. It is interesting that we can so if the clinical decision support has an action in it, I can measure whether the action came from the decision support or the person did it on their own. It just takes a little bit more digging. And Jody's comment, would the second one be adoption if the provider selected it? So passive, so I envision that because there are, for example, the current guidelines have 12 different guidelines. And so I envision that this is a package of decision support and not just interruptive, because really you have to, I think, have a good argument in order to have an interruptive. So the passive, I can still tell who uses passive alerts. And so passive usually exists on the side of your workflow, but you can pull them in and they're measured the same way as active. So I can tell if people have decided to use it, but it's a different way of pushing out information. I don't know if that helps, Jody.
Yeah, I guess I'm just trying to understand the, like, separating all the different parts, because like, you know, you're trying to see to what extent the CDS works, and part of it is that it happens automatically, and then what part of it is the adoption by the intervention agent, in this case the clinician. You know, like, how would you measure what their part of doing this if it goes off automatically and they can't do anything about it? Like, if they act on it based on that they got it?
If they act on it, yeah. I can get to adoption here in a second.
Well, I always like reach and adoption are kind of like opposite sides of sort of the same thing in my mind, you know, so.
Maybe, Jason, this is a key issue, I think, in looking at CDS issues and applying re-aim. It's too bad Katie can't be here because she's gone round and round with several of us on this. And I think part of it may be the way that in this field, you generally use adoption, if I understand it. And the other, Jason M. and Nikki may want to weigh in here too. You've been involved in these discussions, but maybe if you go to adoption and then come back, I think the rest of the group that hasn't struggled with this will get a feel for some of the, I think it's a difference of intersection between re-aim and CDS or decision science that use these terms historically differently.
That makes sense.
So this is reach.
With the adoption.
So how many people accessed it, and then the adoption is that they weren't dismissed and they actually interacted with the CDS. They do sound, I mean, you know, putting them back to back, I agree, Jody, they're very close. And so maybe this is where we need to strengthen the line between them.
Jason, is it interacted with the CDS or applied the guideline-based care? Because that can be two different things.
Yeah, I mean, that's what I'm, it's a great question. That's what I was trying to get at is, so we can, you know, ultimately it'll be deliver the guideline concordant care, because that'll be the difference between those who get the intervention and the control group, right? So that'll be the ultimate outcome. And that's what I'm trying to figure out is, do we only do this, these reach, like somehow that has to be included in the denominator, right? Is how often that guideline concordant care is delivered. Typically, the way that I do it is I run the same, so the CDS gets fired by just Boolean logic, yes, whether it includes it or not. And so I can run that silent in the background. And so I can see the patients which it would have fired for. So meaning we can identify sort of high risk patients without letting the providers know that, and then see what they do during those interactions. So I think ultimately it's going to be, did they get guideline concordant care, to answer your question. But that's what I'm trying to figure out, is that the larger question, or is it more focused on the decision support? This, I only shared a little bit of the objectives. This is a very like data-driven grant. And so I'm trying to be pretty clear with this data part of it, the quantitative part of it, and maybe that's not coming across.
Yeah, and Jason, I think, thinking in terms of NIDA and what they'd want to see the most too, it seems to me like your reach outcome, and you can get at representativeness with this too, is, looking at the number of patients and then how many got the guideline-based care is your denominator. And the way I'm thinking about it, or I would look at it, is that way. And then adoption is, your clinicians and how many of them provided that recommendation. And then you can look at some additional pieces of, how many got alert, how many ignored them, how many, you've got that data to look at some of those additional things. But to me, it sounds like the thing of most interest is really that main outcome of following the concordant care, the guideline-based care. And that's how I was thinking about it when you were first talking about reach and adoption.
Yeah, that's a good point.
There's nothing from preventing you from having lots of other stuff in here. But I worry about purists, re-aim purists, when you start putting different things than what is originally intended for each of these domains, and I found myself putting more in like implementation. I'm trying to look for lots of other things rather than alter the true meaning of what reach is, like how many patients are getting the thing that they need to get, whatever it is to me in that pure sense. And then you can always have like subsets of all of this, different things you're going to look at, like different ways you're going to look at, because what you're trying to do is to get the patients the thing, whatever it is. I'm sorry, not saying that really very well, but the guideline concordant care in your case, they're getting the opioids prescribed, or they're on MAT, or they're, like whatever it is. And then I think it's really interesting. I always get a little bit confused with the adoption stuff when it's an automatic thing. Like what is reach when the patient's like unconscious and you're like administering something to them in the emergency, like they can't even say no, they're going to get whatever. So like, I just get a little lost in those things. So like when you have something that automatically goes on, then how do you measure adoption? Because I don't study those things. Like I like your idea of like, do they just ignore them or dismiss them or whatever as a measure, I guess.
Yeah, I think the part that's hard for me is when you're doing these both, effectiveness and implementation, is how, like, what is the primary outcome? Like, I think the primary outcome of getting the guideline concordant care makes total sense. But then to me, it feels like that's the effectiveness is like the primary, and then implementation's like secondary versus kind of equivalent. And so that's what I'm trying to figure out. Like most of these are written as implementation CDS outcomes, but I think Nikki's right, like that they're most interested in the patient-centered outcomes, or the effectiveness outcomes, which is what happens to the patients or patients receive. This is what I have for effectiveness. And it's sort of now, just to make things more confusing, I've merged those two ideas, which is CDS alerts that led to guideline concordant care. And then the no high risk, that's just not, I think it's probably going to be non-concordant care because the way they've changed the language. And then alternatives. So a lot of the language is about, we're not just decreasing opioids, we're actually providing other forms of analgesia. So, and the alerts, ideally the alerts, we try not to make CDS alerts a stop sign. We try to make them an arrow to make it easier. So it won't say like, don't do that. It'll say do this instead. And the this instead will be alternatives. And so trying to find a way to pull that in as one of the highlights of the effectiveness. And then in my box there is what we just talked about, which is guideline concordant care or CDS actions.
I think, sorry to butt in here. Whoever was going to speak, go ahead, please.
No, it was just me. Go ahead.
I was just, this really is an issue in the juxtaposition of these two fields. I don't mean to perseverate on that, but I've talked with Katie a lot about it. And Jody, on the one hand, I'd agree with you. I'm a little worried the way it goes now, people that are used to using re-aim in other ways, other contexts would get, real upset or say, this is not right. But if she switches, at least in Katie's applications I've seen, to use adoption the way we are, then it really confuses people in this space, in the discipline, and they get upset about that. That's the wrong definition too. So I wonder, this will seem a little maybe surprising to you, but if, particularly because you'll have this reviewed by non-clinicians also, if it might actually help to take the time just to have a logic model or a stepwise or a flow chart or a process map about what has to happen at each of the various steps in order for this to be successfully implemented. And then maybe take the burden off somewhat, talk about where are these steps or actions that need to be happening. And that's kind of the implementation issue, what you're focusing on, whether then technically you call it reach or adoption or implementation even.
Yeah, I have a couple of different versions. I didn't include them here, but I'm trying. So, so I've talked to the program officer, and the feedback I got is sort of what I call, implementation light, which is really they do not want to be confused by multiple theories, models, and frameworks. They sort of want one that makes sense and fits within sort of the data part of this. And so I'm trying to, I definitely need a kind of unifying diagram or process map, I think, and that's something I'm working on. The other part of this is like, and I think I crossed it off on the very first slide, but this third bullet is those are the 4 pillars they're looking at, which is primary prevention. I've crossed off treatment of opioid use disorder and recovery support because our system just doesn't have that data. UC Health does almost nothing for recovery support, and most of the treatment for opioid use disorder is outside of our system. But also sort of within having a higher level as to why the prevention and what we're doing links to these other things at the end, I think is the other feedback that we got, is to sort of present this cohesive argument. Is there a specific study section? There is a specific study section, and they don't tell you who's on it until they get applications, Amy. Implementation, I guess, is sort of, here's just what we have so far. And I guess I wanted to see what thoughts were, with that idea, with the feedback we got, not to confuse people, is if it's worth it adding in frame or the frame IS for the implementation part of it, or to try and spin the newer concepts of iterative re-aim throughout. And so I didn't know if, I know there's probably some biases on here, Russ, but if you all had other thoughts about confusing people, or, making the argument towards re-aim being used throughout. Oops.
What do people think? Again, Jason's
Well-
asking you to kind of be, if you're a reviewer on this, what?
Well, I guess
your
I mean, the part that I like about implementation is it's all like the how, you know, like that you get into the whole, what are the core components of all of this? And, you know, how do you know that those are happening or not? And how much would it cost to do this, which you've got there, or other resources? What other kinds of things need to be in place that it would happen well? What are the workflows? What are the, you know, all the that how it happens kinds of things. And this is your, I don't know, I think this is like the funnest playground area of re-aim, you know, I mean, like you know, it's kind of like the reach and effectiveness is like the patient level what outcomes, and then the adoption is kind of like the setting level what outcomes, but the implementation is like the how it happens. And Russ, I don't know, I'm sticking my neck out here. I don't know if I have all that right, but that's kind of how I've used it. And it's your places to look for, you know, kind of how it happens and how you might not get to the other outcomes because it's not working well.
Yeah, I failed to include as far as resources because I don't know much about costs. So part of this is that there are 4 centers that go along this that are supposed to help in the first 2 years. One of those has to do with cost, sort of sustainability. Another center is about data management, and another one is about sort of identifying best practices. Actually, maybe there's 3 centers. So there's 3 centers plus the grant funding. So there is the opportunity to reach out to them about some of these questions. I think it's expected within the first few years of the grant in order to work on some of this. And one of them would be costs, which is sort of a not black box with clinical decision support, but very not well, I think, quantified.
Well, I guess what I'm just wondering with this kind of mechanism, so I only did this once. And the way that we wrote our application, we were kind of one of those on the bubble frustrating ones that didn't get funded, but it was really close. But what the R61 part was, you had to identify the triggers that determined whether it was effective enough or not. Like you had to show, in our case, it was on insomnia, and it was like helping people get off their narcotic sleep meds. And so we were doing this intervention, which was this insomnia cognitive behavioral therapy thing. And so the triggers, gosh, I don't remember, but it was something like people had gotten to a certain level of titrating off their meds at a significant level compared to the comparison group, you know? Mm-hmm. And so you had to like do a pilot first to show that it like worked at a certain level. And then that was like the first 2 years or something. And then they would release the money for you to do the next 3 years, which was the big study, you know, which was more like the bigger RCT thing. And we did have a lot of re-aim and that kind of thing in it, but that wouldn't get deployed until you got to some of the you know, kind of markers that it would work for the intervention you were trying to do. So I'm trying to wrap my head around like, if that's correct, which that's what I remember, it was probably like 4 years ago, then how does that relate to what you're doing? Like, does your having the CDS fire and be available trigger enough guideline concordant care that it seems worthwhile, and then you would unleash all the funds to do the like bigger study? Is that kind of your understanding, or how?
Sort of. So I mean, it does. Yes, to a point. So this is what I'm also struggling with, is to as to what we've done versus what we need to do. So it does say if you have no pilot data that you can spend the first 2 years proving it.
Right.
So I have pilot data from, I mean, I have an entire project on the old CDC guidelines, and now they're changing them. And so I think the way I'm selling it is, listen, you know, or you know, we have the capacity to link this data to measure outcomes. And we've sort of, we've done some of it on the previous set of guidelines. And so rather than redo all of that, my hope was to spend the first 2 years putting all of the infrastructure in place and proving that we can iteratively, it's a lot about feedback loops. And so that's why I think that this slide for me is most important about sort of the iterative nature of the project, is once we start it and we identify that it's working or not, they're not, the sense I get from talking to them is they don't want to hear 3 years later that it didn't work, right? They want to sort of have these data structures in place so you can say, we did this, this is the best practice, it worked, it didn't, we need to scale up, scale out, or we need to sort of have some framework for making changes iteratively throughout the project. Is that so? I think, Jody, you're right. Like if you have no data, like that's a big part of it. The way that they kind of sold it was more to prove that you can do the second half of it, and some of that we've already done, but we just have a lot of data silos, and the time lags between things make it not. The quality of data that we get is not available to do it like iteratively throughout the project. Like some of the process outcomes, but not the patient outcomes, which is what I think they're interested in.
I think it would be awesome if they actually are looking for what you are talking about, and you've been talking to the program officer. And so, because I think that's what a lot of studies need, is they need the time to kind of iterate and try it out and get, some preliminary data. Because this other study, I didn't feel like we could do that. It was like, you gotta, we had done some pilot work already. So there was, what it was we were trying to convert it to like a virtual platform from an in-person class kind of thing. But there was pilot data on the in-person class already. And so anyway, it was kind of like what you're talking about, like something changed. There was pilot data, but something changed. But if you could iterate a little bit more, that would be great. I don't know at all. I haven't applied to NIDA since then. Like their appetite for things like frame and stuff like that, or they would just kind of go, you don't know what you're talking about. Or if they would say, oh, this is really cool because you're going to refine what you're doing and have it really better when you do the study. So I just don't know.
I think that the problem with it is you have to, and you sort of touched on this, is you have to lay out the whole 5 years in the same 12 pages. So I'm sort of reluctant to switch between a bunch of different frameworks that somebody reading might not know about. I mean, I think it makes more sense to spend a lot of time on one and then sort of have it be the connecting thread throughout the project, rather than sort of have different parts for different sections and then have to sort of re-explain each one and how it fits. And then maintenance, I think, is the hardest for me, clearly, since there's only one sentence here. But I don't know, more quantitative ways to think about maintenance. I mean, in the past, I've turned off CDS to see if people keep using it, right? Was it the decision support that brought them there, or was it the selling them on the efficacy of the intervention? And as soon as I turned it off, people just stopped doing it. So I'm sort of reluctant to do that again. So I didn't know if there were other thoughts as far as how to start really thinking about sustainability more outside of just the qualitative interviews with people. I will say, I didn't say at the beginning, sorry, I didn't make it obvious, but you can either do this sort of within your system and community or within one system. And so I'm just keeping it within our system. So there's the scale up to other settings potentially, but really my hope is to turn it on across the entire system. So there's not a lot of, outside of scaling out to other systems, there's not a lot of opportunity to turn it on more places.
This might be a good application of the, it would add a quantitative measure to the interviews, but the PSAT, would it be the PSAT or the CSAT? Community-based is CSAT. PSAT, I think.
It's a CSAT. The clinical one would be the CSAT, yeah.
I agree to understand, again, Jason's point here about not wanting to confuse them, particularly since I'm going to guess the majority won't be implementation scientists on the panel. You need to think about that, but you certainly could frame these the interviews around PRISM, or I do think the CSAT, is a what people would think of, as a validated tool or whatever that's used there to focus on these factors, if that's what you want to focus on. I guess for myself here, I'd be interested in what their plans are going forward after you get done with your study. And myself, I think the way I'd think about the sustainment issue would be, do they continue to use it after your study's over? To me, removing the CDS would be another experimental thing to look at, and it might be interesting, but to me, just do they use it over time, in the context of all sorts of other changes in the system and priorities and things. But I think the notion is, back to talking about frame or whatever, for me would be the adaptation. How are they going to use this? Are you going to use this in the same way that you rolled it out? Does the CDS itself, need to be adapted? Do they change? Clinicians change where they use it? What about variability across different clinics and things?
Yes, that not to throw a wrench in it, but that's sort of like I think one of the larger questions about clinical decision support is, when do you de-implement it, right?
Yep.
There's most of the stuff that gets turned on in our workflow is garbage, and it's done for some billing purpose.
Yep.
And never goes away.
Yep.
And so what are the criteria to turn it off? And so I think that's very interesting as a larger question. I'm not sure. I can sort of posit it here, but I'm not sure what the cutoff is. A lot of this is sort of, it depends. So like if it's something that's life-threatening, you never turn it off. If it's something that's, maybe beneficial to, 2% of the people, maybe you should turn it off if it's not a life-threatening event. So it's a little bit more challenging because it's not well-defined.
Yeah, I think that's a great question. Just a quick comment, and then I would love to hear other people's take on the implementation, their thoughts about that too. But on that issue, Jason, my pretty strong reaction is that's very interesting, and I think that will just confuse the reviewers. It'll be too much going on here. But what I would really keep in mind is I think that could be a really cool supplement after you're funded towards the end of the project. You need to do it, supplement, so you have at least a year left. But I think this issue here of the de-implementation and stuff is really neat. I don't know you want to mix up the two, is my strong gut level reaction. I think what you have, as you're seeing, is already a little challenging to explain to non-clinicians that don't work with these things every day. But I love the idea, but to me, that's almost a separate grant, or I think you could do it as a supplement later, but I keep it simple and stay away from that now.
Thanks. That's all I had. If anybody else has thoughts, I appreciate it. I know it's a sort of atypical subject for some of us, and it's sort of hard to conceptualize without a ton of pictures about how providers interact with electronic health records. But I appreciate sort of sometimes it's better to get perspective when people aren't buried in this with me.
Yeah, I guess I think it's like just keeping it on, like, what are we trying to accomplish in the big picture, so that reviewers who review for NIDA will say, hey, we want less people to suffer from drug addiction, or, whatever it is. And kind of keep that in front of them, like how it all connects, because you start getting into all these different intricate like implementation strategies for things, and they lose that bigger picture of the what and the why. And so trying to keep that, on their eyes is good.
Yeah. Amy just put in there, and I was going to also see if we could call out Danielle. I think Danielle's typed in a number of really interesting comments and things here, but maybe she just wants to say something verbally. But I just wanted to reinforce her comment, her second to last comment, and say, Jason, this is, I really thank you for doing it. I think part of the growth of this group and things is seeing different applications in different settings and different challenges, you know, and that includes re-aim too. It obviously doesn't work for everything. Some things I think it's really quite straightforward to, at least compared to other models, and others it isn't. And I think it's a learning thing. It isn't necessarily the best for everything. But with that, I'd like to just let Danielle have a word. You have a number of different thoughts here, Danielle.
Sure. Thanks, Russ. Yeah, Jason, I was just wondering for the implementation slide, you know, you have things that you're measuring like adaptations and costs, the clinician experience, but I'm wondering if there's strategies you have in mind to improve adherence to the CDS tool. Like maybe clinicians need to learn about it first before they use it so they're more motivated, or like the reason for creating the tool itself.
Yeah,
just wondering your thoughts on that.
it's a great question. I mean, one of the proposed benefits of CDS is that you don't have to teach people about it, right? That you make it innately obvious as to what to do, but clearly that's not the case for everybody because there are so many different workflows. I will tell you that in the last project, the dissemination of like getting something new into someone's workflow is next to impossible across the entire system, and it's really challenging. So I'll tell you what I did last time. I mean, we have an educational website within the CDS. You can link to the website and go there and learn about it. It also has all the references on there, and it has like a video that walks you through it. And almost nobody went there. So it's like, you know, but how much information do people want? And when we did the interviews as we built the tool, people were like, oh yeah, I want to know sort of why this is firing. And then a lot of the clinicians at the community sites were like, no, just tell me what to do. And a lot of the APPs and nurse practitioners just want to know what to do. And in the end, it looks like most people just wanted the information and really didn't care. They sort of trusted the site to some degree, but yeah, I mean, so a lot of it, particularly like when we start, I don't even get into it here, but like the nudging aspect of it is really how do you make this beneficial to them to use without having to learn a lot about it? Because as soon as you start trying to make something difficult, you just lose people. And so I purposely always make this less clicks to do the right thing than more clicks. And that's sort of manipulative, but it also makes it as obvious as possible as well within the constructs of what the system lets you do. But thanks for the feedback, appreciate it.
Jason, we just interviewed clinicians about prescribing like exercise and for like musculoskeletal pain. And one of the things that they did say was that they felt like they wanted a little more education, to Danielle's point. So I know that, like, I think it's really helpful. I mean, as someone who gets a lot of alerts, I really don't want to know like all the data behind it. Like I understand where people are coming from, but I do think like maybe having some sort of education, like we learned that they felt like, I really don't know what this means. Like, I feel really uncomfortable going through this process because I don't really know what I am clicking or prescribing for someone. So they wanted a little bit more. As far as like how to do that, that's something that we're trying to figure out, like what that level of education should be, because your point is super well taken, that people just are like, it's too complicated. I don't want to like take a class on this. I don't want to do an online training, but I want like something.
Yeah, I also think it's a big difference as to where you work. And I know we're at time here. You know, we have UC Health, which is beneficial on a grant application, but challenging in implementation, is that we have a lot of different settings. And so the people at AMC are sort of, I often jokingly say beaten down, but I mean, our quick adopters of new changes. And so usually once they're told to do something, they sort of get on board pretty quickly and assume that, you know, as an innovative place, that's the expectation. That is not true. It's the community center, community-based practices. And I don't know if you all know this, but UC Health sort of has different levels. And there are a lot of community sites that just use our Epic and sort of practice under their own, it's the practice group, I can't remember what it's called, but that, you know, they're sort of separate. And so getting them on board to do things is very interesting. And it's a different conversation. And so that's why we did so much education and outreach. And, you know, as we've all heard before, what people tell you what they want and what they really want are not always the same thing. So yeah, it's very interesting, this kind of push-pull about providing. We provided a ton of information, multiple ways to give feedback, comments in there, comments on the website, our emails, and outside of a couple of people that got angry because they couldn't figure it out, most of the time, people don't use it. They just sort of decide one way or another. It's very interesting. But thanks, everyone. I know we're at time. I totally appreciate everyone's time and feedback. It's been great.
Take care, everybody.